So we'll be presenting we have about 4 cases for the panel discussion today. Much has been discussed by the previous speakers on thyroid during pregnancy and postpartum. So we'll be concentrating more on hyperthyroidism, which was not discussed. So we'll talk a lot about that, and we'll take questions from the audience for hypothyroid case discussions. So I'll ask Shanmugha to start the case discussion for this morning.
Thank you, Shruti. As he told, a lot has been discussed in the previous session. So we will mainly focus on the practical points. So we are very senior panelists here. So, and we will give more time for the audience interaction also. So the first case is a 24-year-old 10-week pregnant patient presented with symptoms of nausea and early morning sickness. So on examination, she had pulse rate of 78 beats per minute with no clinical features for hyperthyroidism. And TFT results showed free T4 in the upper borderline and TSH is suppressed 0.18 milliliters per liter. So which one of the following is the correct management approach in this clinical scenario? To observe and repeat the thyroid function test after some times, check for TSH receptor antibodies, or start the patient on anti-thyroid drugs, or subtotal thyroidectomy in the second trimester for hyperthyroidism, and do the thyroid uptake scan. Anybody from the audience? Now for number 1, how many? So most of those for observation. For number 2, so few people. So obviously I think number C, D and E will be null. So I will ask the panelist. So anyone? So what is the diagnosis and how to approach this kind of patients? Because it is a very, very common clinical scenario. As an endocrinologist, we get most of the referrals from the gynecologist for this kind of scenarios. So how to approach this kind of cases?
Thank you. So there are 2 things to consider here. One is the clinical picture and another one is the thyroid function tests themselves. So the clinical picture is very typical of any pregnant woman. She could easily have nausea and morning sickness. I think that is very, very common. So we really don't have to worry too much about that. She's not presenting with hyperemesis or situation like that. When it comes to the thyroid function test, you can see that the free T4 is within the normal range, but maybe a bit on the higher side. But the TSH is lower, and we have to keep in mind that there are many changes that take place during pregnancy, and especially in early pregnancy, as Professor Gonell had already pointed out, that in very early pregnancy you will have a lowering of the TSH, which is due to many things like an increase in thyroid hormones and suppression of TSH. That's okay.
There's a common cotton variety that it's a case of a normal case with the initial trimester showing a low TSH and the free T4 in the upper normal range. Now also you must go into the clinical case. If this patient was treated for hyperthyroidism earlier and this patient is having goiter, then one must look into a suspicious thing that whether there is going to be thyrotoxicosis. But normally thyrotoxicosis comes in remissions during pregnancy. But sometimes you get this type of picture in a patient who have been treated for thyrotoxicosis. So that must also be kept in mind while seeing these cases.
So another one question for the panelists. So in such scenario, when you will advise for the anti-TSH receptor antibodies? So whether if T4 is high or in the upper borderline, when will you ask for the anti-TSH receptor antibodies? Anyone?
Unless we have a family history of thyroid dysfunction or the patient has had previous on examination goiter and she has more metabolic symptoms, I don't think we'll straight away go for a thyroid receptor antibody first initially.
Okay. And for the gynecologist, it's a very common clinical scenario in the first trimester between the hyperemesis gravidarum and gestational transient thyrotoxic rarely we see. But hyperemesis gravidarum versus Graves' disease. So clinically, because most of our patients may not be affordable for the anti-TSH receptor antibodies. So most of the times we need to make clinical diagnosis and we need to wait for some time before starting them on anti-thyroid drugs. So practical points how to clinically to make that it's only hyperemesis gravidarum, no need to start anti-thyroid drugs.
Definitely the patient may have symptoms and signs of thyrotoxic anticipating before pregnancy she may give. If there is no goiter, no hypermetabolic symptoms, and only because of excessive vomiting and the patient has ketonuria and hyperemesis there, we can wait for doing the, I mean, if you do the thyroid study and TSH is low, thyroid hormones are higher, but along with nausea, vomiting, no other metabolic symptoms like palpitation and other
Clinically, no signs for
we can wait
hyperthyroidism.
for the symptoms to subside.
Okay, I think this second question, first question has been beautifully covered by the Dr. Colonel. And second question, in our clinicals, in our setting, because we know that assay for free T4 is not very standardized in our country. So what is your take, madam? Whether to go for free T4 or better go with the standard total T4 and just multiply by 1.5?
So I think that was very beautifully, discussed. One of the things is these automated immunoassays, it can be an issue for free T4, but typically they tend to be a little lower in the third trimester and may not have big issues in the first and second trimester. Having said that, the problem with the total T4 is this 50% increase in the T4 is applicable only around 16 weeks. So you're supposed to actually increase by about 5% per week, starting about 5 weeks from, so suppose let's say and calculated from 7 weeks. So suppose someone is around 10 weeks pregnant, you will have to say it's 3 weeks, therefore 3 multiplied by 5, you have to increase the T4 only by 15%. So I just think it's a very work intensive and it could lead to some errors, but that's the calculation, and if you can do that, I think that would be very, very good.
Okay.
So. Pardon? Which one would you do? Total T4 or free T4? So depending upon the assay that you have, and like I said, it's usually a little lower only in the third trimester. So I don't have too many issues in the first and we haven't had too many issues in the first and second trimester. So you can do free T4. Otherwise, you have to do total T4 and use this calculation. If you're ready to do this calculation, total T4.
So any questions from the audience regarding this case? Otherwise, we'll move on to the second case.
So this is a 30-year-old woman who was 8 weeks pregnant. So she presented with mid-early morning nausea and tiredness. So she was diagnosed with primary autoimmune hypothyroidism about 5 years ago, and she's already taking thyroxine, 100 mics a day. On examination, she's clinically euthyroid, and everything is normal. A thyroid result shows a free T4 was done, which is about 1.12, which is normal. TSH is 3.7. So before moving on to the question, I will probably go to the next slide and we'll come to the answers here. What adverse outcomes are associated with overt hypothyroidism during pregnancy? I would like to hear it from the gynecologist.
So it can start from the first trimester. Miscarriages are increased. Then we have preterm labor, which is increased. Preeclampsia is increased. So all sorts of problems, both for the mother as well as the fetus. Then gestational hypertension can be increased, and for the baby we have intrauterine growth restriction, fetal growth restriction can be there, and fetal losses, even stillbirths are quite common, and for the mother we have PPH which can be there. So all these problems are associated both for the mother as well as for the fetus.
Okay, that was great. Thank you. So in this case, I don't think she was overtly hypothyroid. So she is already on 100 mics and she's now pregnant. Can I go to the previous slide? Yeah. She's now pregnant with a TSH of 3.7. So if you see such a patient in the clinic, what would you do? I mean, what sort of TSH, trimester specific TSH would you aim for, and what will we do with the thyroxine dosage?
She actually, after 4 weeks of pregnancy, we have to repeat the thyroid function test. And the reference range for the TSH in the first trimester, it should be less than 2.5. So here it is 3.7. So I would like to increase the dosage of thyroxine. Already she is on 100 microgram. So I will be increasing the thyroxine level. So actually we have to increase a small dose. Then again repeat within 4 weeks the thyroid function test. Suppose if we have not, the TSH is not reached within the reference range, we have to again raise and keep monitoring once in 4 weeks. Once it is stable, we can do the monitoring between 6 to 8 weeks.
Okay. Usha, how do you increase the dose? What sort of dose increase are we looking at this patient? She's already on 100 mics.
Yeah, so I completely would agree. I want to keep it below 2.5 and probably definitely above 0.1. And so I would increase it very slightly. So, something like a 25 microgram, go from 100 to 125 would be good, because usually around this early pregnancy, they may not gain much weight. Later they gain more weight and you may have to actually increase a higher dose, but now this may be enough.
Is there a need to check antibodies in her?
But you already said she has autoimmune,
Yeah.
so there is no need to check.
Perfect. Okay, so that's an important. So another question is, what if this lady was not hypothyroid and she presents for the first time with this first trimester specific range of about 3.7? She's not on thyroxine, not on 100 mics. So would we start her on thyroxine according to the new guidelines?
Yes, no. Yeah, the TSH is 3.7 and her T4 is within normal range. She could be a case of subclinical hypothyroidism. So I will start her on L-troxin and I'll start with the dosage of 1.6 microgram per kg body weight, starting dose.
So, Dr. Gunn, do you have any take on?
I think that in this scenario, in a normal woman who becomes pregnant and has got a value like 3.7 with a normal free T4, I'll wait.
Okay.
We will just, we can check up the autoimmune status of this patient, and we need to clinically also assess this patient, whether this patient is having goiter or any family history of thyroid disease or any other autoimmune factors. In that case scenario, we will see what is really happening in her. Otherwise, I'll just wait. I won't start on thyroxine therapy.
Okay. Dr. Gurnal, do you have anything to add to that?
Thank you. I mean, I would just echo exactly that. I think especially now with the slight change in guidance, I think at this stage, I would not, if the patient was not hypothyroid, I would not automatically be starting. I think I think for years we have slightly over-treated people with thyroxine. And I think the guidance now has recognized that from the subsequent studies, and indeed there is data here from India as well, showing that the reference ranges are actually higher than were in those original ATA guidelines for patients who don't have thyroid disease before we start.
Okay, thank you. So Usha, I also wanted to ask one question. So what if she's overtly hypothyroid and she comes to you and she says, I want to abort the baby? So imagine her TSH is 150 instead of 3.4, newly detected, first trimester, overt hypothyroidism, and she wants to abort the child. What sort of...
Well, try and definitely talk her out of it. I don't think she needs to, terminate her pregnancy for this. You want to quickly render her euthyroid by using higher than the usual non-pregnant dose and render her euthyroid and monitor quickly, monitor frequently to make sure that she does become euthyroid. So I would definitely talk her out of termination.
Okay.
No, so I wouldn't see this as an automatic reason at all for termination. I think, again, you need to have a very careful counselling of the patient in that situation. But I agree that at that stage, you need to optimise the thyroid function as reasonably rapidly as you can.
Okay. Usha, you wanted to say something before this?
No, I also wanted to say that there's a lot of issues with taking the thyroxine, and so that is something that I would spend a lot of time. So if because first thing in the morning on empty stomach, and how much time they need to give between the thyroxine and their coffee, tea or breakfast, ideally 1 hour, but a minimum of half an hour. And that it cannot be taken with, because pregnant women take iron, calcium, prenatal vitamins, all kinds of things. So, and they may have some queasiness in the morning, and they may want to eat something right away. So you have to spend a lot of time counseling them on, because food delays and decreases the absorption of thyroxine, so how they need to take it. And I also would say that iron, calcium, vitamins, everything gets moved to lunchtime or dinner time. And the other thing is, a lot of pregnant women have bowel issues, constipation particularly. So they may be taking like fiber laxatives and other things, or acidity medicines, which can interfere with absorption. So a lot of time spent on how to take it. And most recently, and why I wanted to talk about this particularly, was most recently what I am seeing and my colleagues are seeing are that people are using a lot of millets. Millets have become the fashionable thing to eat in India. So, and millets are interfering with absorption, and many well-controlled women are totally losing control, and that could be dangerous in pregnancy.
No, I just wanted to add one, because a lot of women now, they have a hyperemesis in the morning. There will be some problem in taking the early morning thyroxine therapy. So there are some of the cases which come and they say that they cannot tolerate that tablet at that point of time. And sometimes even they don't take it properly, they have the elevated TSH for a longer time. I think in that cases you can shift to the bedtime. There are some instances where, especially in pregnant women, they have hyperemesis. You can shift the thyroxine therapy at bedtime.
So do we have any other thoughts from any other panelist regarding this case? I think we're going to skip the other questions because we've already discussed during the discussion. So we'll move on to the next case.
So before going to... So the question is whether TFT should be done in the fasting state or it can be done in any time of the day.
No, basically, when you have the proper conducive period is early morning before taking the medicine, because if you do a free T4 and TSH, then there are chances with some laboratory aberrations when you take the thyroxine and doing a free T4 and TSH. So it's better to do it in the morning. I think there are some studies Dr. Sriram has also done, that after taking your breakfast, there are some variations in the TSH.
So Dr. Granan, any take on this? Any comments on this?
So again, we generally recommend doing thyroid function first thing in the morning. There are changes. So if we take a patient who is not receiving any thyroxine therapy at all, so an entirely euthyroid individual, probably the issues are much less of it. But if you've got a patient who's taking thyroxine, if you take the thyroid function tests at different stages in several hours after the thyroxine has been taken, you will get different results. You'll get significantly different results. That forms the basis, for example, of doing a thyroxine absorption test in completely other settings when you're looking at compliance. So generally, we tend to try to do that. It's also worth bearing in mind that natural TSH has a pulsatile rhythm and is higher at night time as well. So not that any of us would be trying to do thyroid function tests at night time, presumably, but if you were to do so, you might again see different results.
So before going to the next case, one question for the panelist. So nowadays, different form, particularly in India, different brands are available. So sometimes patient may be taking one brand this month, and the next time they may be taking the different brand. Whether that affects the thyroid function test?
I mean, definitely, I think they should stick to the same brand, because in that, see, this whole pregnancy is a small window, narrow few weeks, so you don't want to, lose even a week or two when there could be adjustment between things. And I also want to add, though it's not available in India, some people are getting it from the US, this T4, T3 combination. It's not supposed to be taken during pregnancy. So only thyroxine preparations, and some companies are coming out with building the thyroxine with some vitamins and selenium and all that. So please do not recommend any of that. Just pure levothyroxine is the best thing, because they've shown that the T3 that's present in the fetal brain is really coming from T4, T3 conversion that's happening in the brain. So thyroxine is really what is needed, and not T3 or not T4, T3 combination, and ideally a good brand and nothing that comes in combination. And also wanted to add to what Professor Gurnell had said about selenium. There is some data on increasing risk of type 2 diabetes with selenium supplementation. So we don't need more diabetes in our country.
Thank you. So going to case 3, she is 8-week pregnant woman presented with nausea, vomiting and palpitation for last 2 weeks, and she had a very positive family history for thyroid dysfunction. Her elder sister had hyperthyroidism, underwent iodine ablation therapy, and on examination she was dehydrated, tachycardic and had bilateral tremors, and she also had ophthalmopathy and small palpable goiter. And thyroid function tests were typical for hyperthyroidism. Free T4 was grossly elevated and TSH was less than the limits. So, which one of the following is the most appropriate therapeutic approach? First I will ask the audience. So, carbimazole, this 8-week pregnant woman. So, who votes for carbimazole? Okay. Who votes for the observation? Only few. Propranolol? Okay, few numbers. PTU? Very good. Subtotal thyroidectomy? So the obvious choice would be here, I think, between the carbimazole and the PTU. So what's your take on 8 weeks pregnant woman with hyperthyroidism?
The first trimester we prefer PTU rather than carbimazole, because both the drugs, of course, they cross placenta, but carbimazole has got more of embryopathy. It produces more embryopathy when compared to PTU. So we prefer to start her on PTU. It's very obvious that she has got hyperthyroidism. So we should start treating it at the earliest.
Okay. Question to Dr. Usha. So as you told in first trimester, most of us...
Trimester will give PTU and then shift to carbimazole.
So suppose a patient is known Graves' disease, already on carbimazole, and she is coming to us. So how will you approach? Whether you will decrease the dose, because we know that in pregnancy we need to keep the free T4 in the upper normal level, because physiologically that's happening. So whether you reduce the dose or you change the carbimazole to the PTU, how will you approach the case?
So I really think the most important thing is, what would guide me is that I want minimum or no antithyroid drugs on board, because that goes to the baby. So that is really what is my concern. So if the mother is, clinically pretty, decent and has been taken good care of pre-conception, I would consider even taking her off the taking her off the antithyroid drugs and observing, but monitoring more frequently, every couple of weeks, see how she's doing, and then reintroducing the medication. Or I might consider dropping down the dosage, definitely, because I do not want antithyroid drugs to go across to the baby. And women usually tolerate, being mildly hyperthyroid during pregnancy.
Okay. Sundaraman sir, what about how will you approach? Whether you will change the carbimazole to PTU or you will just continue the carbimazole itself during the first trimester?
So in our settings, we continue the carbimazole because already the patient is a hyperthyroid patient. And as far as possible, we'll try to keep the free T4 in the upper normal range. So the best way is to monitor only the free T4, not the TSH level, in hyperthyroidism complicating pregnancy, and keep the free T4 in the upper normal range. Definitely the dose of the antithyroid medication must be reduced, but I think it requires to be continued. And I don't know the usage of propranolol, because there are instances of the various morbidities occurring and due to the fetus and also the mother. And I think the carbimazole, PTU can be used, but in the small dose carbimazole and PTU, I don't think there is much difference. I can ask the gynecologist.
I think all these hyperthyroidism, I will leave it to the endocrinologist to manage, I think. I think that will be a wise decision.
So, Professor Journal, your call on this? PT versus carbimazole in the first trimester.
So the conventional wisdom is that we should switch to PTU, but I would agree. I think the data around the rates of fetal malformations with carbimazole suggests it's still very low, actually. And I think we sometimes underestimate the potential dangers of PTU. And in fact, the dangers of PTU, if you see them, if you ever have a lady who develops fulminant hepatitis on PTU, it's an extremely unpleasant condition and can be fatal or requiring transplantation. So I think PTU is a drug which is okay, but I think it has its limitations. Of course, in all these patients, as we've already heard, we're trying to use the smallest dose we possibly can. So we're hopefully minimizing the risk to either. So in general, if it's a patient coming into pregnancy with thyrotoxicosis with known Graves' disease, of course, we're anticipating that we're going to hit remission at some point, hopefully early in the second trimester. So that's slightly different to the scenario that you presented with this patient in terms of presentation. I presume the original presentation here was meant to be Graves' disease with the eye signs, although if you have it freely available, TSH receptor antibody is worth checking. Here it's likely to be very positive. You've got the eye signs, you've got the family history. This patient appears to have developed Graves' disease in this scenario as it was.
And what is the role of short-term beta blockers?
We have generally tended to avoid beta blockers. There is this concern, and again, as to whether it is associated with sometimes with IUGR. So we generally have tended to stay away from beta blockers, although I know colleagues who do use low doses sometimes in patients if they think they're not dealing with marked thyrotoxicosis and they're just wanting, but it's not something I personally tend to use.
So as Usha told, we like to keep it the pregnant patients should be slightly hyperthyroid. But in patients with Graves' disease and pregnancy, it's very important to monitor the fetus also, because antithyroid drugs can cause a lot of harm in the fetus also. So how will you follow up? So what advice you will give to the sonologist when you are following up this patient's hyperthyroidism with pregnancy patients?
The baby can have, the fetus can have fetal hyperthyroidism or even fetal hypothyroidism. So serially ultrasound should be done to look for fetal goiter. There may be fetal tachycardia, IUGR, oligohydramnios, and also hydrops fetalis can occur if the baby is going for tachycardia and thing. So we have to monitor.
So how frequently you do the anti-TSH receptor antibodies in such patients? Because that's very important, because people who are having high titers of antibody, the fetus are also at high risk for the problems. So routinely people do, madam?
Initially,
Sorry, please go ahead. Shyam.
Yes, madam.
probably the first visit, because she's a Graves' disease, so first visit that will tell us what effect it can have on the fetus. Then it can be repeated at 22 weeks again, probably we can repeat once more.
So again, I think it's definitely worth checking early on to know what you're dealing with, although it's unlikely to change anything at that stage. The biggest predictive value for the TSH receptor antibody in terms of the risk to the baby from a neonatal thyrotoxicosis perspective as well actually comes with the 30-week TRAB, so one measured slightly later in the pregnancy. But of course, we're dealing with the issues intrauterine and also in the neonatal period as well. So we would tend to measure the TRAB at probably 3 points as we're going to try and predict each of those issues. Okay. I have to say that neonatal thyrotoxicosis, again, in my experience, is actually quite a relatively low event, actually, if the pregnancy is managed properly.
Okay. So what is the role of block and replacement regimen in a pregnant patient with Graves? Block and replacement regimen.
So, block replacement?
Yeah.
Okay, so,
Role of block, antithyroid drug plus thyroxine therapy, so to maintain the euthyroid state.
They said we're not supposed to give thyroxine because you give only the antithyroid drugs. If you give more dose of antithyroid drugs combined with thyroxine, it may not help the baby, and the baby may still go for hypothyroidism.
Okay.
so the only time, so what happens when the antithyroid drugs go across the placenta, the baby becomes hypothyroid. And we really can't do too much, though there's some, small data on intravenous or intraamniotic thyroxine. But I just want to say, but what will happen is if there is fetal hyperthyroidism detected by either fetal tachycardia or premature cranial synostosis or IUGR or other issues, then you can treat the mother with antithyroid drugs. And the antithyroid drugs will go from mother to baby and treat the baby's hyperthyroidism. So that is the one situation. If you give the mother antithyroid drugs and she becomes a little low, you can give her thyroxine. So that's the only situation I can think of where you combine the two.
But I usually don't advocate block and replacement therapy in pregnancy.
Yeah.
Just to build on that, I think the patient who you really have to watch out for in this situation is the mother who has had definitive treatment for previous thyrotoxicosis and has been rendered actually hypothyroid, is on thyroxine replacement, and in that lady, that she has no biomarker activity herself for what's happening with the fetus because she is entirely dependent on thyroxine, and those patients, I think, are particularly vulnerable to people missing the TRAB transfer and the thyrotoxicosis in the fetus because they look at the mother and they say, the mother is euthyroid, or she's going to be because she's got no thyroid function of her own. So again, I follow the same principle. So I get a measurement fairly early in pregnancy to know whether the TRAB titer is positive. I check again around about the midpoint, and the most predictive value for the, as I say, the subsequent neonatal situation is in the value around about 30 to 34 weeks.
Dr. Gurnal, in India it's very expensive. It's about 5,000 rupees for, so one test if we have to do, then one trimester.
So in that case, I would use the measurements of the fetal growth and the fetal heart rate, etc., for earlier on in the pregnancy, and I'd use the TRAB around about the 30-week mark to predict.
Any questions from the audience?
You said PTU cause hepatotoxicity, whether it is dose dependent or idiosyncratic, or if you start on PTU, how much time after you should monitor LFT, liver function test?
Yeah, one of the problems is that measuring the liver function test will be very scary because you will often see the liver function test become abnormal. So in actual fact, there's an argument as to whether even doing routine liver function tests in a patient who's otherwise asymptomatic is particularly helpful in terms of predicting that. But in pregnancy, we do watch the liver function tests, and we tend to check them ourselves, usually within if we're using PTU, usually within a week or so of starting the PTU. I think generally it's not, I think both drugs are actually pretty much safe for the majority of patients. All of us are slightly scarred by the odd patient we see where some disaster strikes. So the question is whether we can use longitudinal liver function tests with a set done before we start antithyroid drugs to predict where we're going to get to. Theoretically, it sounds good. The honest answer is I don't know quite what of an increment merits a point at which I'd say I have to stop the drug. I'm not entirely sure, because when it's obviously abnormal, it's obviously abnormal. But when you just see things just increasing a little, are they going to settle at that point or not? Because you can sometimes see the LFTs become abnormal with carbimazole as well, although it tends to be a cholestatic pattern rather than an acute hepatitic pattern. Well, I don't know if anybody else on the panel has an experience, but I'm not sure I know what the threshold is for then saying I have to stop the PTU at this point.
I do not have any personal experience, but all guidelines say that PT-induced liver cell failure is sudden. So how much ever you monitor, sometimes it cannot be predicted. That is what is usually said.
Yes, sir, Dr. Koneth.
I think the panel must state whether antithyroid dose must be trimester specific. First trimester is not equal to third trimester. If antibody positive in third trimester, postpartum heart-wurming exacerbation is 44% of patients. Within 6 weeks of delivery, there is an exacerbation of autoimmune thyroiditis. So I think the PTU dose or carbimazole dose has to be just like TSI, monitored trimester specifically. First trimester is indication is different from third trimester. The uterine fetus monitoring also will be different. So the only other question why Dr. Usha doesn't like selenium supplementation, I want to know. Because selenium 200 milligrams we give as selenium cytothinase, enzyme activity increases. It has been proved. But it is just like taking a Benadryl or pyridoxine or B12 or iron. But why don't you recommend, or you don't want to use it?
It's not me, sir, it's the official guidelines. They are saying that do not give selenium for two reasons. One is there's only a small study that showed some benefit and we need it in larger studies. And second thing is this, trend to increase in type 2 diabetes. So I'm just saying that I do not want to, go there till the guidelines recommend it. But I want to mention one more thing here, Shanmugam. We've been talking about liver. I just want to mention here that both PTU and carbimazole or methimazole are associated with about 2 to 4% risk of some malformations. And that is something that we always think only of aplasia cutis, but there are other things associated with like choanal atresias and esophageal atresias, and with PTU, some neck and facial cysts and abdominal wall abnormalities and things like, though they are kind of minor, but I'm just saying, so that's why I want to be anti-thyroid drug minimalist as much as possible.
So thank you very much. That's a good discussion. I think take-home messages are we should use the anti-thyroid drug as minimal as possible, and both carbimazole and PTU are almost same in safety. It's almost equally efficacious. Safety equally efficacious and also almost equally safe. And we should at least do anti-thyroid TSH receptor antibody at least once in third trimester to know the effect of the fetus. And most important is we should properly monitor the fetus heart rate and the fetus goiter in every trimester.
The thyroid dose has to be adjusted because in third trimester, then the requirement will come down actually. Anti-thyroid drug that we have to reduce.
Okay.
The third trimester. That's what he wanted. The
Yeah,
trimester wise.
fine. Okay, the fourth case, so this is the postpartum thyroiditis case. So it's a case of 27-year-old woman presented with anxiety, palpitation and increased sweating, and she's 8 weeks postpartum, not on any medication. She didn't receive any thyroid or anti-thyroid medication during the pregnancy. So on examination she had bilateral tremors, pulse rate of 96 per minute and no eye signs or no goiter. So free T4 was in the upper borderline and TSH is decreased and TSH receptor antibodies are negative. So which one of the following is the most appropriate management? So how many for the carbimazole, anti-thyroid drugs in this case, 8 weeks postpartum, TFT suggestive of hyperthyroidism. So B propanolol, C propylthiouracil, radioiodine ablation, subtotal thyroidectomy. It's almost no one for any answers. I'll ask the panelist. So what is this case and how should you approach? Again, this is a very common clinical scenario we see in day-to-day practice.
Postpartum thyroiditis after 8 weeks. She's having symptoms of palpitation and increased sweating. Instead of starting her, carbimazole is safe in breastfeeding women also. So in a minimal dose, I can put her carbimazole. And many times when we are starting anti-thyroid drugs, we have to be very careful. I think the symptoms only palpitation. Initially, we may put her on propanolol for a shorter time and see whether how she prolongs. I may repeat the thyroid test after some time and the symptoms of persisting or TSH is very low. Then I may be going for carbimazole.
Okay. Sundaraman sir, any take on this?
No, in this case, postpartum period where she is having only hyperadrenergic symptoms. So I think the propanolol will be the ideal drug of choice in this case, because you know very well that it is going to be a postpartum thyroiditis where there is no, the hypersecretion is not from the gland. It is due to the destruction of the gland as such and releasing the preformed hormones. So in this case, propanolol will be the ideal choice of treatment in this case.
Okay, and another one common question people used to ask us is whether taking thyroid medication affects the lactation or it affects the baby.
Anti-thyroid.
Anti-thyroid or thyroxine medicines, both.
So lactation, actually if they don't take, the problem in lactation will be there in the case of thyroxine. Anti-thyroid, not lot of studies are there on the lactation actually. What is the effect it has?
Anti-thyroid drugs, propylthiouracil is secreted only 0.7%, not 7%, so it is safe. And also carbimazole can be also given, it is secreted in 0.5% in the milk, so you can have of the maternal we can continue giving her antithyroid drugs during lactation. But lactation failure or decreased lactation has been reported in thyroid dysfunction per se.
Okay.
They said in a well-controlled thyroid thing, actually they don't find any
Changes in the lactation.
deficiency. Only when they are uncontrolled they have found. And in hyperthyroidism, they say it is there's difficulty in letdown reflex. The synthesis is okay, but only the milk down. So we have to counsel her, and once she regularly feeds the baby, lactation failure does not occur.
When the mother is on, actually we're continuing anti-thyroid drug, no? We have to closely monitor the baby, neonate. That's very important. The baby can go for hypothyroidism, so we have to closely monitor.
Yeah. So to Dr. Usha, so patients who is established hypothyroid postpartum, many patients used to come with TFT suggestive of hyperthyroidism. So suddenly very hyperthyroidism, very high free T4 and TSH. Whether you decrease the dose to minimal level or you stop the medication and observe and restart the thyroxine after some time. Established hypothyroid in postpartum presenting with hyperthyroid.
Rule of thumb is if someone who has been pre-gestationally hypothyroid and their dosage has been increased throughout pregnancy, as soon as they have the baby, you can go back to their pre-pregnancy dosage. Some may need a slight increase, but most, you can go back to their dosage. If they have been just started during pregnancy and are only on 25 to 50 kind of doses, you can actually stop it and reassess them 6 weeks later. And definitely, I would decrease the dosage, not stop it, but just keep in mind that thyroiditis can actually happen in people who have autoimmune thyroiditis.
So, question for Mark Gunnell. So, postpartum thyroiditis patient in the hypothyroid phase, how will you approach? You will start thyroxine immediately or wait for some times and after to start treatment after some time?
So postpartum thyroiditis are now in the hypothyroid phase. So hypothyroid.
Hypothyroid.
Yeah. Okay, so I'd be interested in knowing what the TPO status of the patient is as well, because that's predictive of whether we're going to be into long-term hypothyroidism, what I'm going to do further down the line. It's pretty difficult when you've just had a baby coping with everything else in life. If you go hypothyroid, it can make life really quite tricky. So I often replace those patients. But if they're TPO antibody positive, I tell them there's a likelihood this may become a long-term phenomena. If they're negative, then I'm going to try them off thyroxine at some stage further down the line. And when you do that differs, I often tell the patient that we'll monitor their status, optimize them, and review where we are at a year. Some people prefer to do it sooner than that. Some people do it at an earlier stage. If they're TPO positive, then as I say to them, don't expect to come off. You can anticipate that you may well need long-term thyroxine.
Okay. Any questions from the audience?
Hello. If TSH receptor antibody comes in third month positive, whether in India we really do stimulating antibodies or blocking antibodies, and if they are, say, we did again in 6 months, it is increased, say, so what do you do to the fetus, or anything is there from?
If
okay, I need to hear the question again. So
Yeah,
this is
the question is, if you do TSH receptor antibody, I think in India we don't do actually the different, like TSH stimulating or blocking. So whether you really want to do repeat test with both stimulating or blocking, because it will actually give a futuristic outcome in the neonatal period actually for the fetus, and how you monitor the fetus.
Okay, so again, this to some extent can be partially answered depending on what the maternal status is. So if the maternal status is with an intact thyroid, then I have a bioactive readout of what the TSH receptor antibody titer is that she has, because if she's got a stimulating TRAB and she's got her own thyroid, she's likely to become thyrotoxic. If she has a blocking, she may become hypothyroid. The real problem is in the mother who's actually, as it were, rendered hypothyroid on thyroxine replacement, and I don't have a bioactive readout to that at that point in time. Interestingly, we don't actually routinely discriminate between blocking and stimulating antibodies. Our assay is an immunoassay that simply tells us that the presence of TRAB is there, because actually to measure the activity then requires a more complicated assay, which most people don't have access to be honest. So then I go clinically, either by mother and or fetus stroke child.
Well, I have a general question. So I had a patient who brought me this book called Thyroid Diet for Dummies. I don't know if you've seen that. There's a book that actually says it's a diet for thyroid, which is actually new to me. So when you see a patient with hypo or hyper, would you be really giving them any diet advice, or, they come up with all sort of interesting stuff from the internet and then they ask you this question. So how do you approach that?
So, like I mentioned earlier, I think millets are really important to, bring up in the discussion. But other than that, people usually talk about cabbage and cauliflower and maybe some radish. Repeatedly, it's cabbage and cauliflower. How much cabbage and cauliflower do we eat? And also, we're not in a iodine, deplete state anymore. So please just tell them. I tell them you can eat what you want, do what you want. If they are hyperthyroid, I ask them to be on a non-iodized salt. Hyper. Other than that, I don't put them on any restrictions except millets.
No, the only thing that is important is the soya-based food. So if they are taking soya-based food, they have shown that it decreases the absorption of thyroxine replacement. So that is the only thing that we must be carrying out. So the soya-based product must be stopped.
I think we have just 2 minutes more. Yeah.
So can we include soya for lunch or dinner instead of breakfast, or
Yeah,
no to complete
definitely.
soya?
Yeah, it only decreases absorption of the thyroxine at the time of the treat. Just like taking the sucralfate or iron or calcium, that must not be combined with the thyroxine, that's all. It doesn't mean that the whole day they cannot be out of soybeans. That is, it impairs absorption of thyroxine.
The same question with millet, can it be used for dinner or it should be completely stopped?
See, I think millets are not this issue of primarily absorption. There other mechanisms, and we are not fully aware of that. So what I tell them is, in moderation, they can include, every now and then something. But lately, it had become a fashionable thing to go on a completely millet-based diet, and repeatedly we are seeing this issue. So just something to bring up with them.
Already fortified. We have iodized salt only. So already I think enough iodized. We are taking enough iodine in our food.
No, the fortification can be done, and it's better to take fortified food. Like fortified salt, it's better to take it. There's no contraindication for the fortified salt.
So last question. Should women be universally tested for thyroid function before pregnancy? I think it must be universally yes. Universal screening before who are coming for pre-conception counseling.
Yes, but that is the Indian Thyroid Association clearly states that it has to be done. Although other bodies don't recommend. They said in high-risk conditions, it has to be done. And they lay out high-risk conditions like obesity, which is quite common, and family history of thyroid. So all these things, I think we have to say it is probably should be tested universally. And our Government of India guidelines also say,
Universal screening.
Basically, the other countries, it is insurance-driven investigation. That's the reason why they don't do the universal screening. But I think that in India, that the universal screening, I think it's a must.
So I think we have finished within the time, only 7 seconds more. So I thank all the panelists for wonderful discussion and the co-moderator Suti for the discussion, and also thanks the audience. Thank you.
Hello. We had a very nice discussion. I invite Dr. Sridhar, President ESTN, to present memento to the speakers. Dr. Shanti Gunasingh. To Dr. Anjalakshi Chandrasekhar. To Dr. Premalata. to Dr. Usha Shriram, to Dr. P.G. Sundararaman, I invite Professor Nihal Thomas, HOD, Endocrinology, CMC Vellore. Mementos? Others. To present mementos to the moderators, Dr. Shruti,
Please come to the front, sir.
Thank you.
Dr. Shruti, Dr. Shanmugasundar, Dr. Sundararaman. Now on to the next session, a themed symposia on diabetes, obesity and vitamin D. I invite Dr. Muthukumaran Jayapal, Director ARCA, Senior Endocrinologist, to the dais, and Dr. Jayashri Gopal, Senior Endocrinologist at Apollo Hospital and Sitapati Clinic, to be the chairpersons.
Good morning and welcome to the next session, which is going to be a series of talks about the thyroid and vitamin D and obesity on reproductive outcomes. For the first talk, I'd like to invite Dr. Jairani Kamraj onto the dais. She is the Chief Consultant in Infertility and High-Risk Pregnancy, founder and director of the Akash Fertility Center. She also holds several other positions like the Secretary of the OXY, and she's been the first lady to be appointed to the World Association for Sexual Health, and I think that's a great privilege that she has been bestowed upon her recently. Dr. Jairani is here to talk to us about obesity and reproductive outcomes.
Good morning. Thank you, Chairpersons, for this nice introduction. At the outset, I would like to thank the organizers of this Trendo for giving us this opportunity to talk on obesity and reproductive outcomes. And on behalf of OXY, I have the great pleasure to thank Trendo for making us join in this wonderful Congress. So my talk will have this content, the introduction and the significance.